This is an online version of a session I've been doing around the hospital lately, just to demystify clinical supervision, because it's not as spooky as it sounds. The trouble with clinical supervision is that word supervision. It sounds like scrutiny. It sounds like you've got somebody leaning over your shoulder telling you what to do all the time. It's not like that at all. And just to prove this, there are some naming traditions which don't really make a lot of sense today. So, for instance, I will assume that there's a fair chance that if you're watching this, you either have a Bachelor of Nursing or Nursing Science or a Bachelor of Midwifery. And I reckon there's also a fair chance that you're not actually a bachelor. And all that tells us is that some naming conventions don't make sense in 2019, but they probably made sense when they first got started using, first started being used. So I'm sure universities back in the, whenever it was, 14, 15, 1600s, I think, is when they first started talking about having a bachelor of whatever you were studying. They weren't really thinking about nurses and midwives and people who weren't single men going off to study. So it is with clinical supervision. The name sits on a tradition which is 100 or so years old now. It comes from psychotherapy, where people doing psychotherapy were aware that they were in deep conversations with people and thought it'd be a good idea, rather than just rely on their own judgment, is to go out and seek some supervision around their practice to just make sure that they weren't missing stuff that would be really important to the other person. So clinical supervision was actually driven by the people who were practicing psychotherapy, not by an organisation of psychotherapists who were imposing it on them. People wanted that for themselves and for their clients. And for mental health anyway, clinical supervision has long been embedded in the practice of psychologists, social workers, psychiatrists, where they get clinical supervision regularly. We, the mental health nurses, were a little bit bemused that it wasn't until 2009 that mental health nurses were included in the clinical supervision guidelines for mental health services. And there was a 2003 version, I think it was, where mental health nurses were explicitly excluded, which seemed very strange to us. Anyway, so they came out in 2009, and I had a bit to do with rolling out some training and information, a few other bits and pieces around clinical supervision at the time, which is why I know a little bit about it, and I'm really enthusiastic about clinical supervision. It's great. You may have seen that in April 2019, the Australian College of Midwives, Australian College of Nurses, and Australian College of Mental Health Nurses put out a joint position statement which basically said clinical supervision should be available to all nurses and midwives, no matter their level of training and experience. And it's something that they can see the benefit in for people's practice and for their safety of themselves too, because we do emotional labour, of course. It's not just knowledge and skills. We are up close and personal with people who are often having some of the worst days of their lives. Which brings me to this nice little picture which I've stolen from Ian Miller, who used to work as a nurse in the emergency department down one of the hospitals in Canberra, and he had on one of his blog posts about patient-centred care and how care goes in towards the patient and crap will come out. And what's really nice about this is that nurses and midwives and doctors and allied health people are also included in this picture, where even though we're providing the care to the patient at the bedside, we might need some care coming in from the outside too, and an avenue for some crap to come out. And this is, I guess, part of what a big part of what clinical supervision is all about, as I see it. It's about care coming in and an avenue for some of the crap to come out. Why we would need an opportunity for crap to come out? Well, we experience countertransference. Just as a reminder, you would have heard that word back in uni, but countertransference is the emotional reaction we have to the transference that patients bring to us. So somebody might come in and subconsciously you remind them of wicked Auntie Marge or something, and so the moment they walk through the door, before you've even said a word, they're being really irritable and cranky with you, and that person, that patient, doesn't consciously know that they're transferring those feelings onto you or projecting those feelings onto you, but they are. And we wouldn't be doing a particularly good job as a health professional if we just snapped back and got all a bit sweary and da-da-da and let our countertransference run free. When we go to work, we like to impersonate a health professional, and the health professional will hopefully notice their countertransference and find a way to manage it. The other part of our work is that we see people who've gone through terribly traumatic events sometimes, and sometimes those traumas are physical and or emotional or both, and of course that's going to have a knock-on effect for us from time to time. It would be foolish to think otherwise. So we're getting exposed to all this trauma, and that's going to have a knock-on effect for us too. And so it matters that we find a way to manage that stuff well. Here comes the depressing part of the story. This is Australian suicide data, and they looked at suicides in Australia from 2001 to 2012 and compared doctors, nurses, allied health with other employed people. And I'll just go straight to the left-hand side there where the nurses and midwives are. And you'll see there that female nurses and midwives take their own lives at about 3 times the rate of females in other professions. And male nurses, not quite 3 times the rate of their female colleagues. So our work, I think, is this data shows that our work is probably putting us at risk from our mental health point of view. And so all the more reason we think about finding ways that we look after ourselves better. How do we look after ourselves better? Well, let me just go off on a little bit of a tangent. About 100 years ago in Wales, the coal miners in Wales said to their bosses, look, we go down into your mines all day, we get covered head to toe in coal dust and crap, and then at the end of the shift we walk home to our miserable little miners' units and get washed up and wash up our clothes and wash up ourselves on our time. And we're just thinking, look, we get dirty on your time, we really probably should get cleaned up in your time too, using your water and stuff. And the mining bosses said, oh no, we can't possibly do that, you'll send us broke. So they went on strike. The miners stayed on strike for many months. Some of those mines were shut down for over a year, I think. And at the end of it all, the mining bosses relented and could see the sense in providing their staff with pithead baths. And that was a place where at the end of the shift, you get cleaned up using our hot water, and you leave your dirty overalls behind, and then you go home after you've been cleaned up. And you remember back to Todd and Brandt and the Beaconsfield mine collapse a few years ago, and they were underground for a fortnight, and they would have been living in each other's excrement there during that time. So they would have been pretty filthy by the time they got out of the spot that they were trapped in. However, there was infrastructure in the mines that allowed them to get cleaned up, to shower and shave and change clothes and shampoo before they clocked off. And this is them clocking off after being underground for a fortnight. They got cleaned up on the boss's time. It was part of the infrastructure. Now, nurses and midwives don't tend to get covered in coal mining dust and stuff all that often, but we do emotional labour, and so we are just thinking maybe we should get cleaned up on the boss's time too. And that's what clinical supervision is all about. The 3 functions of clinical supervision as described by Bridget Proctor are the formative, normative and restorative. So the formative is about the knowledge acquisition and improvement, so learning new things and honing new skills are all part of the formative. The normative stuff is making sure that you practice within all those codes of conduct and the policies and procedures that govern our work. And the restorative part of clinical supervision, the bit that I really value, is around looking after the emotional side of things. So they're the 3 functions of clinical supervision. You might be thinking that that's going to be expensive to take everybody offline to sit around and talk and think and reflect on their practice, but I would counter that with two arguments. One is it's something that is being made available to our allied health and psychiatrist colleagues forever, as far as I know. So it's okay for nurses and midwives to think that they deserve that same level of self-care and practice improvement. And also, it's not just about us. It's shown that people who, or workplaces that provide clinical supervision, have an improved quality of patient care. And so we would be providing a better service to patients if we do go ahead and do that. The stuff that's in place at the moment, like the employee assistance scheme and the nurse midwifery support line, are really good, but they're the repair parts of looking after nurses. What clinical supervision is trying to do is the maintenance, so it doesn't get to that point where we're at breaking point. So what comes next? I think just keep an eye out for what information is going to come our way. The Queensland Nurses Union and the Australian Nursing and Midwifery Federation have been talking about clinical supervision for the last couple of years, and keeping in mind it was the unions that helped us get in universal precautions in the 1980s. The AIDS epidemic helped that along too. It was the unions that gave the no-lift policy a nudge so it became embedded in the 1990s. It was the unions that really pushed for ratios to be introduced, and in the 2010s, and I'm hoping in the 2020s it'll be the union that helps us get clinical supervision embedded in our practice too, because as I say, it's going to be good for us and good for our patients. If you need any more information about any of this stuff, in the website there at the bottom, that metaphorrn.com/self-care, I've got links to all of this info that I've introduced you to. Thanks for watching. Cheers.